This is my topic today, recurrent anterior shoulder instability, our treatment options. We know that the glenohumeral joint is the most frequently dislocated. It is due to its particular bone anatomy and extended physiology, range of motion. The stable shoulder depends on the interaction between dynamic and static stabilizers, but when this stabilizer relation is broken, it may happen luxation or subluxations, micro instability, or a traumatic instability. After the first dislocation episode, many patients can recover their stability, but many others evolve to instability. There are well-known predisposing factors for this: males, young people, contact or collision sports, and associated bone injuries. These are the basic anatomic lesions after dislocation, like a bunker and heel sag. They are frequently small, but with recurrent dislocation, could evolve to more bone loss, weak capsule, and inferior glenohumeral ligaments. I think that's important to identify and treat associated injury, like extensive labral lesions, sometimes plus slap, as we can see here in different posterior arthroscopic views. The ALS, anterior labral periosteal leaf avulsion, here on the left a chronic MRI and on the right an acute MRI, and these are different anterior superior arthroscopic view of these kind of injuries. Or the Hagel, less frequent humeral avulsion of the glenohumeral ligaments. In the clinical examination, we have some important information to inquire, like different characteristics of the trauma and the luxation. We have to assess scapular dyskinesia, like in this patient. When we have patients like this, we usually perform rehabilitation before surgery. We have to assess the axillary nerve status if there is a parallaxity or voluntary dislocation as well. We do the application test at 45 and 90 degrees of adduction and external rotation. We know that when you have bone defects, we will see more instability signs and they are easy to reproduce. Other important tests are the Salker sign and the Sherp test to evaluate the posterior instability. I think that's important to perform the stability shoulder test with the patient under anesthesia before surgery, because we could obtain more information about the stability direction and the soft tissue and bone status. There are special X-rays incidents like a Westpone or a Stryker to evaluate inferior glena and heel sag, but today I think that's mandatory to do an MRI and CT scan. We have important tools to the preoperative planning, like a glenoid index. This is a relationship within the less diameter of the inferior two-thirds of the affected glenoid with the contralateral glenoid. When you have less than 0.75, that means 25% of defects, that indicates bone block technique as Latarjet or similar. Our understanding of the bony defect measurement has evolved since 2000, when Burkhardt and De Ver talked about the inverter pair. In 2007, Yamamoto and colleagues explained the glenoid track concept, and in 2014, Di Giacomo and colleagues explained the on-track and off-track heel sag lesions, taking into account the bipolar defects. We know that if the medial margin of the heel sag lesion is within the glenoid track, this is an on-track lesion. On the other hand, if it is more medial to the glenoid track, it's an off-track lesion. This is the original paper in which the author explained how to measure the bipolar defect with the glenoid track concept and using CT scan arthroscopic measurements. Basically, they suggested two main techniques. When you have more than 25% of glenoid bone loss, they indicate Latarjet. When you have less than 25%, an arthroscopic bunker. And they add a remplissage procedure in every off-track lesion. Other important tool to the preoperative planning is the Instability Severity Index score, so-called ISIS. In this paper, Ball and Boileau, in a prospective study, evaluated 131 patients with arthroscopic bunker, all with anterior instability. They found 19 cases of recurrence. They determined risk factor for this recurrence. They stated 10-point ISIS score. Here on the table on the left, we have the different variables that they found. And when they had more than 6 points, they found an acceptable recurrence rates of 70%. So they concluded that with more than 6 points, the bunker, arthroscopic bunker is a contraindication, and they suggested the Victor Latarjet in those cases. This year was published this paper, Glenoid Tract Instability Management Score, Radiographic Modification of the Instability Severity Index Score. This was the main objective of the authors. They add the glenoid tract concept to ISIS. They compare decision-making with ISIS versus time, this is the new score, using 3D CT scan versus X-rays. When they had more than 4 points, they indicate lethargy. When they had less than 4 points, they indicate an arthroscopic bunker. Finally, using the ISIS score, they indicate lethargy near 70% of the cases. On the other hand, using the new score, time, they indicate lethargy only in 14% of the cases. So they concluded that using only X-rays may lead, like ISIS, may lead to lethargy over-indication. But how much bone loss is critical? There is some international consensus in taking into account 25% as critical bone loss. But last year, several authors started to talk about the subcritical bone loss. In this paper, the author presented 73 cases of military population. They divided in 4 groups regarding the bone loss. They found a failure rate of 12%, and the WOSI, the Western Ontario score, was higher than mean worse in defect over 13.5. So they concluded that this percentage, 13.5, is subcritical because may lead to lower WOSI, Western Ontario score, even in patients who did not have a recurrence of their instability. In this other paper, Ichoy and colleagues evaluate 43 patients with less than 40 years and less than 25% of glenoid bone loss. They divide in 3 groups the patients. They found a recurrent rate of 7%, and the WOSI for group 3 was significantly lower than group 1 and 2. So they concluded that the glenoid bone loss between 17 and 25 is the subcritical for these authors, mostly in males and contact athletes. And they suggest lethargy in those cases like in the first paper. So in this both paper, they found different percentage as subcritical basis in the WOSI score because this percentage lead to low quality of life of this patient, but it's not clear why this patient had this result without recurrence of the instability. As regards the treatment, our objectives are to obtain a stable and functional shoulder, return to sport with the same activity level. There is a non-surgical management, but it has low success in young and active patients with instability. Our indications are low demand and comorbidities. As regards the surgical options that we are managing are the arthroscopic bunker, the open bunker plus capsular sheath, and the lethargy is our third option when we need a bone block. The arthroscopic bunker today is our most frequent surgery in number of patients. Our indications are anterior rehabilitative first surgery without or small bone defects. There are authors that extend the indication to defects with less than 25% of bone defects or less than 6 points of the ISIS score. We have to be prepared to fix associated injuries, to evaluate the interval, and to perform a remplissage if it is necessary. Here on the right, the typical patient for arthroscopic bunker for us, 25 years old, 3 anterior dislocation with a bunker and 5% glenoid bone loss and a small heel touch lesion. We perform the technique and the lateral decubitus and longitudinal traction. It's important the portal placement. We usually do 3 portals, 1 posterior and 2 anteriors. And we follow the proposed steps for reattach the labrum to the anterior glenoid, as we can see here in the video on the right. The open bunker plus capsular sheath is a technique that has been reconsidered by several authors in the last year, like Arciero in this paper. They indicate the open bunker in different clinical scenarios, as we can see in the list here on the left. Our indications for open bunker are 10 up to 15% of glenoid bone loss with non-tract lesions in revision surgeries after failed first surgery, sometimes in contact or collision sports. Call my attention how this technique has been reconsidered the last year. This is a picture taken the last American Academy meeting. The last year, these authors published their own modification of the open bunker, and they explain their indications: failure arthroscopy revisions, hyperlaxity, multidirectional instability, or contact or collision sports. Just to remember, the open banca plus capsular sheath, as the classic manner like Neer and Foster, has several modifications, like this one in 1991, the glenoid-based capsular sheath. This is a typical patient for our open banker indication. 22 years old, he had a prior arthroscopy 8 months before. He was referred for another center, presented pain and anterior instability. In this kind of patient in which we plan a hardware removal and we suspect a soft tissue, we don't doubt in performing an open banker. When we need bone block, our fair option is the Latarjet. Remember the triple effect: the bone block, the capsular reconstruction, and coracoviction sling. Our indication in general, more than 25% of glenoid bone loss with big bipolar defects with an off-track helical lesions. But as we said before, there are authors that extend the indication as a subcritical bone loss, 13, 17%. An author that extend in every revision surgery. It's important the graft position to avoid condyle injuries and non-unions. And this is the typical patient for our Latarjet indication. Multiple dislocations, more than 25% of defects. It's important to follow the different steps proposed to avoid complications, because as we know, Latarjet sometimes has several complications. This is a patient with a failed Latarjet male, 43 years old. He was operated 1 year before. He had a new trauma and he presented pain and instability. In the anterior posterior X-ray, we can see a broken screw, and in the CT scan, we can see a coracoid non-union. This is the important instability with engaging anterior dislocation with the patient under anesthesia. In this difficult scenario, we prefer an autologo iliac crest like Eden Avinet procedure. We can see complications and recurrent rates in every technique. Why? There are relative patient factors, anatomic factors, but we must avoid our technical factors: failure to identify causes of the instability, failure to recognize pathological lesions, inadequate techniques, or inappropriate rehabilitation. As final considerations, the treatment must be according to the patient and pathology scenario. We have to analyze advantages and disadvantages of every surgical options, recognize bone defect sizes, labrum injury extensions, and uncommon lesions. The outcomes in general are according to these items. Pay attention to post-operative care and the rehabilitation. We know that arthroscopic banca and Latarjet are most popular today, but remember and consider the benefits of the open banker too. Thanks for your attention. We'd like to invite you to the Argentine Society online courses. Thank you very much.